Okay, good morning, everyone. Time to get going. I think summer is definitely over, judging by the weather conditions. So this morning we have two talks, and both address, I think, severe issues in the United States that we're dealing with. Of course, there was a lot of attention focused on the opioid crisis, and it's still huge, but has taken a little bit of a backseat with the political season and also with the COVID pandemic. But nonetheless, it's with us. It's here to stay for the long run, and we really need to make some moves against it. So the first talk this morning is the opioid crisis, its interface with plastic surgery. This will be delivered by Dr. Aaron Mason, who's an associate professor in plastic surgery. He's the section head of pediatric plastic surgery. He's a native of Pennsylvania. He did his undergraduate training at Washington and Jefferson College. At University of Pittsburgh, he did his medical degree training, pediatric residency, so not pediatric surgery, but pediatric residency. He did his general surgery residency and then did a plastics fellowship, again, all at the University of Pittsburgh. He then left to go to really one of the top programs in the world in craniofacial surgery, to Toronto Sick Children's. He's been on faculty at UT Southwest, MUSC, and most recently West Virginia, where we were successfully able to recruit him from within the last year. Since arriving, he's done a wonderful job organizing the clinical activities, not only on this campus, but off campus, and organizing the research program, and of course, giving a tremendous educational experience to both the fellows as well as to the residents. So Aaron, thank you very much for giving this talk this morning.
My pleasure and good morning. Thank you for that introduction, and I want to thank everyone for participating in this morning's half hour. What I want to talk to you about is the opioid crisis and its impact upon patient care and surgeon risk. And this is somewhat of a personal journey, as I am a native of the actual state of West Virginia, not Pennsylvania, though I trained in Pennsylvania for everything, but grew up in West Virginia, and then went back about 6 years ago. And it's that experience in the 6 years that I was there that kind of informed the topics that we're going to talk about today. And within this half hour, I wanted to just identify the recognized increased incidence of facial clefting in infants exposed to opioids in utero, identify how the crisis alters patient care paradigms, and identify how regional opioid prevalence impacts surgeons' surgical risk of exposure to hepatitis C. And as I mentioned, this is somewhat of a personal story, and there certainly are two experiences that drove it. And the first was in 2016 when we opened the Pediatric Craniofacial Center at West Virginia University. And it's noteworthy at that time that West Virginia had the highest incidence of neonatal abstinence syndrome in the United States. For those who may not have an interface with NAS, it's the experience that the infant has during withdrawal from in utero opioid exposure. And it's marked by increased fussiness and excessive crying, irritability, poor infant feeding, tachypnea, febrile episodes and diaphoresis, and hyperreflexia and overall generalized increased tone and jitteriness. Oftentimes the infants will also have episodes of seizure activity as well. It affected a notable number of infants with orofacial clefting, and that was an anecdotal experience initially. But care for these infants became more challenged due to their withdrawal episode and also to the associated social factors that impacted the first 2 years of life. So we looked at some data from the Department of Health and Human Resources, and if you look at this chart, for the period between 2001 and 2016, the resident drug overdose mortality rates between West Virginia and the rest of the United States were notable. Particularly in the period between 2010 and 16, there was a marked rise, a doubling in the incidence of mortality rates. And these paralleled what we saw in the state, where we had greater numbers of patients in the emergency room with overdose episodes. We had a marked rise in infants in the neonatal intensive care unit recovering from in utero exposure. And on the plastic surgery service, we had a marked peak in admission rates for hand-based infections, as that was one of the favored routes of entry of the drug through the patient population that was using opioids. And indeed, as I mentioned, when we looked at the statistics from the Department of Health and Human Resources, neonatal absence syndrome in West Virginia was strikingly greater than the rest of the nation. And by 2014, it was about 5 times that of the nation at large. This was evidenced in our own unit having a population at any given time of about 40% who were withdrawing from in utero opioid exposure. And so with that, as I mentioned anecdotally, it became apparent to me that it seemed as though there was a higher number of babies with palatal clefting in that patient group. And so we set out to look at that and ultimately published this study in last year that did find that there was a higher than suspected frequency of palatal clefting in those babies who were withdrawing from in utero opioid exposure. And we did this by retrospectively looking at patients who were admitted to our neonatal intensive care unit or were delivered in our institution between 2013 and 17, and identified 11,599 newborns. Of that, the total population was divided into those who were withdrawing from intrauterine exposure and those who were not. We identified about 1,179 infants who were affected with abstinence syndrome, and the remaining were not. And within each of those groups, 8 and 17 cleft patients were identified. And we compared these two groups. And what we found was that there did indeed exist a correlation between those babies who had been exposed in utero, suggesting that there was some influence of that exposure in the development of orofacial clefting. Those who were not exposed had an incidence of clefting of about 1.6%, or 1.6, sorry. And that was consistent with national expectations for the incidence of clefting. Those, however, who were exposed in utero to Subutex or methadone, 2 commonly used medications in the treatment of opioid addiction, had a higher incidence at about 6.79. What this evolved to was an impact on subsequent care. As I mentioned, in hospital, there was a far larger number of infants remaining in the units for greater than 100 plus days. There was a larger number of infants discharged to either poorly compliant parental care or to a foster care system that was not prepared to handle the large infusion of volume on delivery. Interestingly enough, the state became so challenged for foster care that that care was outsourced to neighboring states where there were those who were able to assist in the care of that patient group. From a cleft care perspective, nasoalveolar molding was affected. Nasoalveolar molding is a technique used in the first 3 months postnatally for infants born with cleft lip and palate that capitalizes on the maternal circulating estrogens in the first 3 months. And what it does is it expands the soft tissue elements of the lip and reorients the alveolar or gum line elements such that things are more aligned at the time of ultimate repair. What we found was it was more difficult to initiate this modality in infants who were withdrawing, in large part due to their significant irritability. And the perception was that it was exacerbating that. And so we had to delay the initiation of treatment in that way. We also found that once the infants graduated out of hospital, that the care provider's ability to consistently perform what was needed, even though it wasn't particularly complex, was challenged, and that the success with the treatment was mitigated. Timely follow-up was also a challenge. Infants discharged to less than optimal family situations often didn't make it back for appointments, and certainly in the instance of nasoalveolar molding, their surveillance exams were affected, which affected outcomes. From a surgical perspective, cleft lip repair, which is typically organized at about 3 to 4 months of life, was often delayed, again, because of difficulty keeping appointments in preparation. At that time, we were piloting our telemedicine adventure in the Eastern Panhandle in Martinsburg. And even though we had this as a potential resource, it was difficult to get patients to attend those sessions. And so even though geography, which has longstanding been a challenge for the state of West Virginia, we overcame that via telemedicine. The addictive components that made up the family unit mitigated success in getting patients to the operating room. This also was seen in the patients who came to palatal repair, which was typically and would typically be planned at 12 to 18 months of life. But again, there were delays in keeping appointments, not showing up for operating room, and not being able to coordinate care with our otolaryngology colleagues. Team care, which is a hallmark of cleft care, really one of the first multidisciplinary paradigms in clinical care, was also challenging. We typically try to have these patients in, as we do here, in the first several months of life for their first team visit. And again, having an ability to have the patients or the foster providers bring the infants in was challenged. The downstream effects of this were noteworthy, and some families even withdrew from the programming, which made giving them coordinated care even that much more challenging. So overall, we saw a notable impact on our ability to care for this patient group, where we had large numbers of infants in the NICU for extended periods, large numbers being discharged into foster care, difficulty with compliance and follow-up visits and its negative impact upon molding, negative impact upon timely surgical interventions, and overall team care was affected. Our experience was not unique. And so within the same interval, Silverstone in the nearby state of Ohio was looking at a cohort of in utero infants as well. And what that group found was that in a survey of 18 central Ohio providers, looking at 2,200 infants, there was a significant impact on the healthcare system financially at about $133 million. And their recommendation was that there needed to be better coordination and provision of care at each stage of what they deemed the cascade of care. And this included prevention, prenatal care and drug treatment, labor, delivery, and aftercare. We had certainly seen the impact on aftercare, and so had developed a strategy for the patient group. We identified that greater resources were needed to provide care for the group that included more attentive coordination. We had a phenomenal care coordinator who really stepped in and up to the challenge and really became the pseudo parents of this patient group that allowed for us to more successfully care for them as they went through their treatment strategies. Cross-disciplinary education was needed across all groups that participated in care. We realized that discharge to home needed to be contingent upon a neurodevelopmental assessment. This became evident as the children grew into their first and second year of life, where delays became identified either secondary to their environment or to their primary in utero exposure or a combination. A home environment that was safe with supportive services was recognized as a necessity, and a continuity of care within the multidisciplinary team was certainly cultivated. Team members became an integral part of a greater multidisciplinary team. We realized that we often were the only group that was interfacing with the patient and family. And the patient oftentimes would come in having never seen or been part of a family doctor or a pediatric visit. So they were missing their immunizations or other pieces of care that should have already been delivered. So we became a touch point for trying to make sure that they remained engaged. We had to cultivate an awareness of the challenges and needs of that population within the team. And we recommended again that visits provide interface for developmental assessment, much like those that we provided for our craniofacial patients. And we recommended that visits provide interface for a social setting home environment assessment, and we integrated a social worker into all visits for this patient group. And we certainly developed an ownership of the population to provide support and interventions for each point of contact from birth through childhood. What we learned was that our neighboring state of Virginia was marching through a similar cascade, and it was interesting to see the parallel evolution of the two programs between the Richmond program and ours, and reaching a place where we could provide care for the patients in a way that was kind of comprehensive, but at a level that owned them more so than we had historically. So then with this, about 2 years into this, another event occurred that kind of interfaced with the opioid crisis. And that was in 2018, when a 28-year-old female with a history of hepatitis C presented with a large seroma around the right saline implant that she had had placed for an augmentation mammoplasty. And during the case, I became exposed to the seroma fluid, and it set me to thinking a little bit about the relative risk of being a practicing surgeon in general to hepatitis C, but more specifically being a practicing surgeon in a state which likely had a higher incidence due to its touch point with opioids and intravenous drug use. Of note, hepatitis C affects more Americans than HIV disease, yet it is underreported and underrecognized. West Virginia, as I mentioned, has a high incidence of intravenous drug use, which is a known risk factor for hepatitis C transmission. At that time, pharmacologic treatments were coming online that could eradicate the virus, but unfortunately were not universally available to patients, in large part because of insurance-based criteria necessary for release and use. Some perspective, looking at the reported number of acute hepatitis C cases in the US, if you look between 2010 and 2016, there again is a marked rise in the number. As a matter of fact, it triples. These are just reported cases, which is noteworthy. But this parallels the rise in the incidence of opioid use in the Ohio Valley at that time. So what was the relative risk for hepatitis C transmission to an operating surgeon, and specifically a plastic surgeon in West Virginia? We knew that sharp injury intraoperatively or during patient care could lead to transmission and therefore disease, and that the expense was noteworthy, particularly if the insurance carriers were not able to release coverage for affected patients. And so looking at data from the American Society of Plastic Surgeons and the CDC, state-by-state data, looking at workforce data collected by our society, and then those data collected by the CDC on hepatitis C rates, we developed proxy variables for the relative risk of hepatitis C exposure and found some interesting outcomes. West Virginia itself, as a practicing surgeon, had a significantly higher relative risk for exposure than the nation at large. The Ohio Valley, which are the 5 states seen here, Ohio, Pennsylvania, Indiana, Kentucky, and West Virginia, also had a notable increase in relative risk relative to that of the rest of the nation. And finally, Appalachia in general had a similar elevated, or not similar, but had an elevated risk as well. All of this was noteworthy because, again, at that time, particularly, the opioid crisis was rampant in the Appalachian Ohio Valley region, with West Virginia sharing a large volume of the patient burden. What we found in looking at it was because of our relatively fewer numbers of providers, at that time we had 20 operating plastic surgeons in the state, and the higher incidence of hepatitis C seated in the population, indeed we were at a higher risk and should make some plans accordingly. And so what that informed was a greater awareness overall and a move toward changing some policy and behaviors in the operating room. I had not been a huge practicer of double gloving to that point, but quickly altered my strategy in gloving. And I can tell you one of my arguments had been that my sensation would be altered, and it truly is not that different. The risk to self and family is not worth not evolving a strategy that involves protecting yourself. The other thing that evolved or that became developed was the construct of an instrument station. And what we used was a metal kidney basin where all instruments were passed and seated in the basin before another individual picked it up and transferred it. Again, attempting to reduce the risk of injury and thereby disease transmission. The last thing that became apparent during the study was that we really need a better system whereby we report and track the incidence of transmission so that we can be better informed. In doing the analysis, we looked at all 50 states, and some states were not able to be analyzed simply because the reporting system wasn't there to draw that kind of data. So in summary, the opioid crisis has levied a significant impact upon healthcare systems in general. Certainly in those areas where the incidence of use is higher, its impact is felt more so. I've noticed since being here the last 9 months that the DORA, the Department of Regulations, has started an initiative whereby the prescribing of opioids will be tracked through the system. This is something that we had evolved in West Virginia about 3.5 to 4 years ago in an effort to monitor the prescription and the use of opioids by providers, and also to track where those drugs go, and to develop programs to mitigate the overuse of opioids in general. Surgeon's risk is notably different regionally, again, due to the relative number of providers and relative number of those affected. Mitigating risk includes developing awareness of that risk and practicing behaviors that prevent transmission. While this can sometimes be the most challenging, changing behavior is difficult, but it's one that we have to recognize that we need to step up to and promote. Patient care is notably affected by those with opioid addiction. And not only in adults, but in children alike, we need to develop different paradigms for care that allow for success in our delivery of that care. Compliance is a challenge, leading to delays in care and procedures. And there's a need to better coordinate and provide care at each stage of the cascade of care. And this often involves a greater ownership of patient and those who support the patient. I'll take questions now, and thanks for your attention.
So, Aaron, thank you so much. And I actually have a couple of questions. Before I go to the questions, though, I want to encourage people to use the chat function if they have questions also for Dr. Mason. So the first is, you suggested an association with maternal opioid use and cleft palate. And is that just a surrogate and just an association, or is it cause and effect? And has anyone, for example, perhaps heavy opioid users also have poor nutrition, are deficient in some vitamins, so on and so forth? And is there an animal model for cleft palate? And can you study that by using opioids in the fetal period?
Yes, so I'll do the last first. So there is a model in several organisms. There's a mouse model for clefting. So certainly it could be studied in vivo. We did control for those other items. So in other words, we looked at folate and multivitamin delivery in the prenatal period. We looked at smoking, we looked at diabetes, we looked at other potential recognized maternal influences that could lead to clefting that have been recognized so far. And those were all controlled for, and there were no differences between the two populations. It's difficult to prove cause and effect. It's largely, and has still held that, orofacial clefting, particularly labial and palatal clefting, is a multifactorial disease or multifactorial occurrence. And so proving cause would be somewhat challenging, just given that total otherwise understood understanding of clefting. I do think, though, what we identified was that there was a higher association, And so I don't think we can prove cause and effect, but we can certainly say that within that population, there's an incidence that's occurring that's much greater than we would expect in the general population. And having control for those other factors that we do recognize potentially can lead to clefting, we did not find anything else that contributed other than that of the exposure to the Sibutone or methadone.
Yeah, and my second is more of a comment, about double gloving. I think if you're a surgeon, you're crazy not to double glove.
Yeah.
And I did my residency at the height of the HIV pandemic in Baltimore, and 1 out of 3 trauma patients was HIV positive. And so I just, during training, I just started double gloving. And, so, some of you might call me a clumsy surgeon and all that kind of business, but I don't think it's affected my dexterity at all. And it's just something you get used to. And, I think having 2 barriers of protection with a solid needle injury pretty much protects you from HIV or hepatitis C transmission. Now, hollow bore injuries, I think, are a different matter. Those don't wipe the inside of the needle as well. So if any of the trainees or any of the faculty are not double gloving, you need to rethink that.
I would second that entirely, having converted myself, but yeah, I completely agree. My own argument was disproven after I finally stepped into the right space, but I would agree double gloving is absolutely an essential if you're going to protect yourself, to protect your other patients, and to protect your family. Absolutely.
Yeah. And, as a matter of fact, single glove operating feels weird, whenever I've done that for short periods. So, I just don't do that.